Good morning, everyone. I'm Dadi Hassan, postgrad 2 resident at the National Ear Care Center, Kaduna in Nigeria. So today I'll be presenting an overview of oropharyngeal squamous cell carcinoma. And all the contents are referenced and there are no copyright infringements intended in the making of the slides. So these are some of the abbreviations used in the presentation. So the case presentation, is a patient that we are currently building up for definitive treatment at the moment, but I felt it's also important for me to share. So it's a 45-year-old male who presented a couple of days ago to our facility with a 4-month history of throat pain and a 2-month history of dysphagia, both of which have been progressive over the few months prior to presentation. The gentleman had also a history of progressive odynophagia, foreign body sensation in the throat, muffled voice, and some blood-stained salivas occasionally. He also presented with upper neck swellings, left otalgia, nasal regurgitation of fits, and he reported progressive weight loss and lethargy in the last 1 month before presentation. He had also smoked cigarette with a pack here of 3, but does not ingest alcohol, and there are no other history of significance. So at presentation, he was pale, dehydrated, with a borderline BMI. In the oral cavity oropharynx examination, he had some trismus and poor oral hygiene, and he had some pooling of blood-stained saliva, especially on the left side. There was this ulcerated mass seen on the left lateral pharyngeal wall, involving the tonsillar fossa, both anterior and posterior pillars, and also extending to some portion of the soft palate, medially and superiorly, but does not reach up to the midline. So clinical evaluation of the neck reveals presence of bilateral level 1 to 3 lymph nodes, the largest being on the left side, measuring 4 centimeters. There was no other examination findings of note. So he had an ultrasound-guided fine needle aspiration cytology, with the results turning to be metastatic squamous carcinoma. And from there, we proceeded to do a next CT scan, which I'm sorry I couldn't upload the CT here, but it localizes the tumor to the left lateral pharyngeal wall. There was no invasion into the pterygoid plate, and however, it also showed presence of bilateral lymphadenopathy suspicious of malignancy on both sides of the neck from level 2 to level 3 on both sides. So we did a biopsy of the mass, and the histology came out to be keratinizing moderately differentiated squamous cell carcinoma. So the gentleman was anemic, and he was having a poor performance status and function. And so he underwent MDT evaluation, and currently he's being resuscitated for a possible definitive treatment, which is surgical excision of the tumor with bilateral neck dissection and possibly a post-operative radiotherapy or chemoradiotherapy, as the case may be. So some challenges currently being faced in managing this patient include the leg presentation, of course, as is common with a lot of head and neck cancers in the low resource setting, such as ours. And then on non-HPV status at the moment, poor finances from the patient. Here, a lot of patients have to pay from out of pocket, and also poor function with the patient. So all this may delay institution of definitive treatment for the patient and probably could impact on the prognosis. So a little bit of an overview of management of oropharyngeal squamous cell carcinoma. I'll be taking the following outline. So the incidence of oropharyngeal squamous cell carcinoma has been on the increase in the last couple of decades. And most of these oropharyngeal cancers are HPV associated, accounting for up to 80% of all the oropharyngeal squamous cell carcinoma. And this has been on the increase over the last few decades, so much so that this has now been recognized as a silent pandemic. And majority of the HPV-associated oropharyngeal cancers are associated with the type 16 human papillomavirus cell types. The HPV-associated cancers have a different clinical and prognostic outcome when compared to the HPV-negative oropharyngeal cancers. And majority of the oropharyngeal HPV-negative oropharyngeal cancers are commonly associated with tobacco, smoking, and ingestion of alcohol, and that portends a poor prognosis in them when compared to those who have HPV-positive oropharyngeal cancers. However, among those who have HPV-positive cancers, the presence of tobacco smoking and ingestion of alcohol portends an even poorer prognosis in such categories of patients. So this is a data from the USA showing the increase in the prevalence of oropharyngeal cancers over the last few decades, as you can see by this dotted straight line here, where it is shown here that the incidence of oropharyngeal cancers has been on the increase, while that of the cervical cancer has been on the decrease. So much so that it's been said now that oropharyngeal cancers have now overtaken cervical cancers as the most common HPV-induced cancers. And even when other subsites or other regions in the head and neck are considered altogether, the oropharynx account for significantly higher number of HPV-associated cancers when compared to, say, the oral cavity, the larynx, and other sites of the head and neck. So the graph here also another data from the US showing an increase in the prevalence of HPV-associated oropharyngeal squamous cell carcinoma compared to HPV-negative oropharyngeal cancers. The recent data in Nigeria from the HPV information centers have shown that the crude prevalence of oropharyngeal HPV-associated cancers in male is 0.14 and in females 0.11. That same year, another study by Benjamin et al. Found that 17% of all oropharyngeal cancers are HPV-associated. So the subsites for the oropharynx, which have different predilection for formation of oropharyngeal squamous cell carcinomas, include the tongue, the soft palate, the tongue base, which extends from the junction between the anterior two-third and the posterior one-third posteriorly. Then the lateral pharyngeal wall, including the tonsils, the pillars, and also the tonsillar fossa, then the posterior pharyngeal wall. Then this diagram here shows the musculature of the tongue base. This bulk of musculature here is the genioglossus, which is of prognostic importance in patients, especially who have tongue-based oropharyngeal squamous cell carcinoma. Involvement of this muscle portends poor prognosis and may restrict swallowing and other forms of mobility with the tongue. The presence of lymphoid aggregates within the oropharynx, which is known as the Walden's ring, also is important in the pathogenesis of oropharyngeal cancers, particularly as it has to do with HPV-positive cancers. This is because these lymphoid aggregates do not contain basement membrane, which is an important factor in the harboring the human papillomavirus and also formation of carcinoma in situ. So as we progress further, you will see the significance of the absence of the basement membrane in the Walden's ring. Then it is important also to appreciate the vasculature and the blood supply and drainage of the oropharynx, as some of these arteries may be identified and ligated, especially during procedures such as radical tonsillectomy, particularly the lingual arteries, the facial arteries, and other arteries that arises from the external carotid artery. So pathologically, majority of oropharyngeal cancers are squamous cell carcinomas, with the majority being from the lateral pharyngeal wall and the least from the posterior pharyngeal wall. Other forms of cancers that may be found in the oropharynx include the lymphomas and the minor salivary gland cancers. So when comparing HPV positive and HPV negative cancers, we will see that HPV positive cancers are usually seen among younger individuals with high social class and high educational status. They are more often than not likely to be non-smokers with no history of significant alcohol intake. And this portends good prognosis in them. As against HPV negative cancers, where it is commonly seen among much older patients and with low socioeconomic status. They are usually the history of cigarette smoking and ingestion of alcohol. It portends a poorer prognosis in this category of individuals. The commonest culprit in HPV positive, as highlighted earlier, is the HPV serotype 16, but other subtypes of the human papillomavirus include the subtypes 18, 31, 33, and many others. As against the HPV negative, which is commonly caused by alcohol, tobacco, and some genetic instabilities. The main mechanism by which cancer formation occurs in the setting of HPV positive cancers is due to activation of these proteins E6 and E7, which inactivates the proto-oncogene, the tumor suppressor gene, that's the retinoblastoma protein, and occasionally the P53 tumor suppressor gene or protein. That leads to formation of instability, genetic instability, and formation of cancer. So histologically, commonly, the HPV cancers are usually non-keratinizing. They are most commonly poorly differentiated cancers, and they tend to be smaller and ulcerative in nature grossly. And also, they have a high nodal tumor load when compared to HPV negative cancers, which is commonly caused by mutation of P53 protein, and it's usually non-keratinizing and with some form of differentiation, moderately to well differentiated. Then they tend to be, grossly, the cancers tend to be large and exophytic in nature, with less bulky tumor load in the neck, in the nodes, when compared to HPV positive cancers. So the tumor progression may be well lateralized or well localized, or may progress to involve contiguous structures. And sometimes there could be metastasis to distant original lymph nodes. Metastasis usually occurs via lymphatics or blood, and the common sites of metastasis are the lungs, liver, and bones, which commonly is seen in up to 15% of cases at the time of first presentation. Then regional metastasis into the lymph nodes are commonly to level 2, 3, and 4, but sometimes level 1 and level 5 may also be involved. Then it is also important to note that about a third of patients may present with clinically negative neck, and also sometimes the presence of a second primary tumor, especially in the lungs, may also be present in some of these patients. So there are three broad patterns of presentation for patients who have oropharyngeal squamous cell carcinoma. A category may present with a clinically evident primary tumor with an enlarged cervical node. Another category may present with an evident primary tumor with an absent cervical lymph nodes. Then the third category may present with an occult primary with an enlarged cervical lymph nodes. And the symptomatology may vary from those who may present asymptomatic and are being diagnosed sometimes during routine investigation, or sometimes the symptoms may be vague and may mimic a sore throat or pharyngitis at the early stage. And then sometimes, especially in the low resource setting where patients present late, commonly they present with overt symptoms of odynophagia, otalgia, other symptoms suggestive of malignancy. So for those presenting with lateral pharyngeal wall cancers, the common symptoms may include throat pain, odynophagia, referred otalgia, and neck swelling. If the tumor is well lateralized, the neck swellings may be on the ipsilateral side. For tongue-based cancers, in addition to the symptoms earlier highlighted, they may have impaired tongue movement, speech problems, swallowing difficulties, muffled voice, and sometimes they may have feeling of lumpiness in the throat. And sometimes they could also present with a bilateral neck swelling, especially for tumors that are located on the central aspect of the tongue base. For soft palatal tumor, these are also tumors that are non-lateralized, so they may present with bilateral neck swellings in addition to nasal regurgitation of fees, palatal ulcers, and even epistaxis. Then posterior pharyngeal wall tumors, which are rarely seen, may present also with throat pain. This type of tumor is also non-lateralized, so it is not uncommon to find the presence of bilateral neck swellings in such patients. Then about 16% of patients may present with evidence of malnutrition, such as weight loss and lethargy, anemia, and the rest. And other systemic evaluation may reveal epistaxis, may reveal hemoptysis, bone pains, jaundice. These are markers of to suggest metastasis to distant organs. In the oral cavity oropharynx, there may be presence of trismus, especially when the pterygoid plate or pterygoid muscles have been involved. And the tongue may have limited mobility, especially when the tongue base is involved and there's a deeper penetration into the bulk of the muscle. And also in the oral cavity examination, tonsils and the pillars, the palate, all the subsides of the oropharynx need to be investigated and examined, and that may reveal the presence of a primary. And then that is preceded by a palpation, but this should be done with caution, especially for tumors that are located more posteriorly, especially on the tongue base or the posterior pharyngeal wall, for fear of bleeding and exsanguination, especially for ulcerative ulcers. So the neck also needs to be examined to clinically stage the patient in terms of the nodal involvement, the size, the consistency, and of course, a complete head and neck evaluation to rule out evidence of second primaries or involvement of other contiguous areas. So investigation for patients presenting with oropharyngeal squamous cell carcinomas may be broadly categorized into two: specific investigation to ascertain the diagnosis and stage the disease, and then baseline investigation to prepare patients for treatment and to correct any deficit that is noted. So for patient presenting with clinically evident primary tumor and clinically evident neck disease, such patients should have an ultrasound of the neck, both on the ipsilateral side and on the contralateral side. And that is followed by ultrasound-guided FNAC of suspicious lymph nodes. Then after that, computerized tomographic scan and or magnetic resonance imaging of the head and neck should then be followed depending on local guidelines and local protocol and availability. Then it is also recommended that after that, the computerized tomographic scan and PET scan of the thorax and abdomen should then be done to exclude the presence of asynchronous tumors or metastasis to the chest and deposits in the abdomen. When that is done, then an examination under anesthesia of the whole aerodigestive tract is then performed in order to ascertain the extent of the tumor, the relationship to contiguous structures, whether it is fixed or is not fixed, and then a biopsy could then be taken for histological analysis. Those presenting with clinically evident primary tumor with no neck disease should proceed to have neck CT scan or MRI, depending on local protocol, and then followed by CT scan or PET scan of the chest and abdomen in order to rule out deposits in those regions, then followed by examination under anesthesia as earlier highlighted. However, the third category may present with an occult primary with evident neck disease and absent primary tumor. So such categories of patients should have an ultrasound of the neck, both on the ipsilateral and contralateral side, followed by ultrasound guided FNAC of any suspicious node. After that is done, computerized tomographic scan and or MRI of the head and neck should then be done. If a primary tumor is seen with the MRI or CT scan or both, CT scan of the chest or PET scan of the chest and abdomen is then followed. Then that is then followed by EUA of the upper aerodigestive tract and biopsy of any primary tumor that is seen. However, if after the CT scan or MRI of the head and neck, no primary tumor is seen, a whole body PET scan is then recommended to be done. When the PET scan is positive, an EUA and biopsy of where the positive PET scan is noted is then performed. However, if negative, a repeat EUA and of the aerodigestive tract may be undergone, performed, and then sometimes it's also advocated that an ipsilateral tonsillectomy on the site where the node is noted may be done with ipsilateral tongue-based mucosectomy. Some have also advocated a contralateral tonsillectomy and tongue-based mucosectomy on both sides. And then some have also said that one could also take some biopsies from the piriform fossa, the fossa oropharyngeal, and other subsites in the oral cavity and hypopharynx just to be able to establish the presence of a primary. So sometimes in the presence of evident primary tumor, the recommendation is that, especially on the tonsil, the recommendation is that biopsy should be done straight away. This is in order to establish the histological diagnosis and then plan for definitive treatment. But when there is no obvious primary tumor, but one is suspecting that the primary tumor could be in the tonsil, that usually presents a dilemma. The traditional dictate is that a diagnostic tonsillectomy should be done, but this usually presents some challenges. For example, it may compromise the surgical margins. It may also make it difficult for revision surgery subsequently after making a diagnosis, and it may also impact on the decision on the adjuvant therapy to be given subsequently. So the current dictate is that once is suspecting a primary tumor in the tonsils, in the absence of an obvious tumor within the tonsil, a core biopsy from the tonsil center should be taken, avoiding the margins, and then from the beginning, a radical tonsillectomy, either using the transoral route or the robotics or the laser, or using cold steel should be performed. In the first instance, it allows for establishment of diagnosis, and then also it does not compromise with surgical margins, and definitive treatment can then be offered with ease. And then in the second instance, it allows for extirpation of the tumor at the same time, and then taking a sample for diagnosis as well. So in facilities where HPV testing facilities are available, it is recommended to assay both the specimen taken from the lymph nodes and also from the primary tumor for viral assay using in situ hybridization for viral DNA or some viral markers using immunohistochemistry or in situ hybridization. Then the light-based detection test, which is a relatively newer technique that is used to follow up patients who have undergone treatment or patients who have been investigated to having an occult primary. So it is based on the principle that certain type of tissues takes up light of certain wavelength, blue light of certain wavelength, and then they fluoresces. Normal tissues usually fluoresces green, while abnormal tissues, especially pre-malignant or malignant tissues, may fluoresce dark brown. So those areas, once identified, could then be biopsied. A recent study by Wyers et al. Reported that this technique in diagnosing occult primaries have been shown to have high sensitivity and even specificity. In the absence of CT scan and MRI or PET scan in low recess setting, the African Head and Neck Society guideline have recommended the use of chest X-ray and abdominal ultrasound in evaluating deposits or metastasis to the chest and abdomen, respectively. The staging for oropharyngeal cancers are broadly categorized into two. For those who present with HPV positive cancers, they have a different classification in the 8th edition of the AJCC TNM classification. The T classification is based on the size of the tumor and the extent of the tumor involvement. And the extent of tumor involvement It is basically similar to the T classification of the HPV negative cancers, However, in the HPV positive cancers, there is no TIX, which is carcinoma in situ, as I earlier highlighted. This is because of the absence of basement membrane, and then also the fact that a pre-malignant lesion have not been identified in HPV positive cancers. And also you could see here that the T4 has not been subdivided into 4A and 4B. This is because the two sub-classifications have not been found to have any prognostic value. So it has been merged in the current classification of the 8th edition into just T4. The nodal classification also has some differences when looking at the HPV positive cancers. For the clinical classification, it is based on the size and then laterality of the tumor, the lymph nodes. However, surgical data have found that the size does not really impact much on the prognosis. That led to the development of the pathological classification, which is rather based on the number of lymph nodes that have metastatic deposit in them. 4 or less lymph nodes have that is staged as N1, and then greater than 4 lymph node metastasis is staged as N2. Then this is the group staging. For the HPV negative cancers, the classification is similar to, for the T staging, is similar to that of HPV positive cancer. The only difference is that in this classification, TX, which is TIX carcinoma in situ, have been included, and then there is a subdivision of the T4 into 4A and 4B, as there is a prognostic difference between those who present with T4A and T4B following treatment. However, for the nodal classification, there is not much difference in the pathological classification and the clinical classification of the HPV negative cancers, and this is the group staging. So the treatment approach for patients presenting with oropharyngeal cancers is multidisciplinary and also multimodal, as shown here. So before treatment, it is important to ascertain those who may require some form of resuscitation. Very few patients may present with nutritional deficit. Some may present with airway compromise, and that has to be addressed either using tracheostomy or other forms of management. And then those who are to undergo radiotherapy as form of treatment should also be assessed, undergo dental assessment, and any curious tooth should be extracted prior to administration of radiotherapy. Also, those presenting with nutritional deficit should also be optimized, either using nasogastric feeding or using gastrostomy or jejunostomy, depending on local protocol and availability. Speech and swallowing assessment also, especially in patients that may be undergoing radiotherapy, it is important to commence these patients on some swallowing exercises before radiotherapy and also during the treatment. This may improve some quality of life associated with radiotherapy, especially the difficulty in swallowing. So the modalities of treatment for patients presenting with oropharyngeal cancers include surgery plus radiotherapy, or radiotherapy alone. So for those presenting with early disease, surgery, especially when the tumor is resectable and the patient is fit for surgery, surgery alone could be a modality of treatment. However, after surgery, if the histology returns to have no adverse features such as closed margins, extracapsular spread, or presence of multiple lymph nodes with metastatic deposit, then the patient should just be followed up. But patients presenting with adverse effect or features should undergo a post-operative radiotherapy or chemoradiotherapy. Then for patients who have resectable tumor but are not fit for surgery or have opted for other forms of treatment, radiotherapy alone could suffice, especially when talking about early disease. Then for those presenting with advanced disease T3 and T4, the modalities of treatment include surgery plus adjuvant chemotherapy, chemoradiotherapy or radiotherapy, and then primary chemoradiotherapy or radiotherapy. So radiotherapy can be done, is particularly done as a standalone treatment to preserve function and organ preservation as well. It is particularly sensitive for HPV positive cancers. And the conventional therapy is usually given at 70 grays in multiple fractions of 35. However, this particular regimen has been shown to be associated with increased toxicities, and people have advocated the use of different fractionation regimen. Another form of standalone treatment when talking about radiotherapy is to include a chemotherapeutic agent. The chemotherapeutic agent commonly used alongside radiotherapy is cisplatin. However, this agent have been found to be associated with a lot of toxicity. So there are some de-escalation modalities that have been proposed, such as substitution of cisplatin with carboplatin, which has laser toxicity, or reduction in the dose of cisplatin. But a recent meta-analysis by Stoch et al. Have found no difference in the overall survival, even when cisplatin have been halved the dose from the conventional dose of 100 milligrams per meter square. So another de-escalation recommendation is to substitute cisplatin or with cetuximab, which is a monoclonal antibody. This has been shown to improve survival rate and also local regional control with low toxicities. So some special scenarios where radiotherapy alone may be used include in patients that have distant metastasis, some combination of chemotherapeutic agents such as cisplatin with 5-fluorouracil and taxol has been recommended. This has been shown to improve overall survival and local regional control and decrease metastasis, but this is associated with increased toxicities. Another regimen is to use cisplatin alone. Cisplatin with 5-fluorouracil. This has also been associated with reduced distant metastasis. Indications for post-operative chemotherapy, chemoradiotherapy, include tumor factors such as positive or closed margins and also perineural or lymphovascular invasion, and then nodal factors such as multiple lymph nodes that are involved, and then extracapsular spread. So surgery. The role of surgery is to extirpate the disease, the primary disease, and also to do some other adjunct surgeries such as neck dissection and also for access. So the commonly performed surgery, surgeries can be done transorally or via the open approach. The transoral surgeries, commonly the lateral oropharyngectomy, or the use of transoral laser micro surgery, or the use of transoral robotic surgery. These are not usually available in low resource settings. So sometimes we deploy the use of cold steels to do some lateral oropharyngectomy. So for the transoral surgeries, it is best suited for early tumors T2 and T1 to T2. It is a minimally invasive procedure that is usually aimed at organ preservation. So the transoral laser microsurgery is governed by the tumor anatomy. It involves taking marginal biopsies in a plain pieces, and then intraoperatively, once the resection is completed, if the margins are free, then resection is deemed completed and patient is then managed subsequently. Then if the margins are closed, adjuvant radiotherapy or chemoradiotherapy is then administered. But if the margins are positive, resection is advocated, or a post-operative chemoradiotherapy can then be done. For the transoral robotic surgery, which is a more standardized en bloc resection, it is a non-tumoral en bloc resection where the whole tumor is resected alongside surrounding normal tissues. For the tonsils, it involves the removal of the tonsils, the pillars, some part of the soft palate, the lateral pharyngeal wall, including some structures in the parapharyngeal space. When the margins are free, resection is deemed completed. And when the margins are closed, especially if it is mucosal, a re-resection is then advocated. But when the margins are deep and not mucosal, it is regarded as pathologically high risk, and this patient should undergo post-operative chemoradiotherapy. So the use of transoral surgeries, especially when combined with neck dissection, have been shown to improve significantly survival rate, local regional control, as shown in this various study, whether one uses the laser microsurgery or the transoral surgery, it's been associated with good tumor control and overall survival. However, when the transoral surgery is combined with post-operative chemoradiotherapy, it's been shown to be associated with low quality of life and increased toxicity. So for those presenting with negative neck, some have advocated the use of neck dissection to treat the neck electively or selectively. This is because of the findings that up to 1/3 of patients may present with micronodal metastases at the time of presentation, and then also due to the fact that it is difficult to pick the earliest conversion from N0 to N1 during routine follow-up. So the modality of treatment in this case using neck dissection is the selective neck dissection, level 1 to 3, with or without addition of level 1, and level 2 to 3 with or without addition of level 1 and 5. Then for well-lateralized tumors, an ipsilateral neck dissection will suffice. But for non-lateralized tumors, say tumors on the tongue base, a bilateral neck dissection is advocated. However, some are of the opinion that for negative neck, it is radiotherapy can also suffice, and then there is no difference in the rate of disease control when comparing neck dissection and radiotherapy as primary modalities of treating patients presenting with negative neck. And for the well-lateralized tumors, it is advocated to radiate the ipsilateral neck, and then for non-lateralized tumor, the radiation should include the bilateral neck. However, for patients presenting with positive neck node, selective neck dissection should be performed from the beginning, including level 1 to 3, depending on whether or not the tumor is lateralized or not. Recently, it's been advocated that chemoradiotherapy alone may also suffice in treating the neck for patients presenting with positive neck disease. For ipsilateral tumor, just like the previous scenario, the ipsilateral neck is irradiated, and for bilateral tumors, the bilateral neck is irradiated. So the indications for open surgeries include for access, reconstruction, and for other procedures. So one of the access commonly used is the mandibulotomy, which may be paramedian or median mandibulotomy. These have an excellent access. It exposes better the tongue base and the lateral pharyngeal wall, and can be used to extirpate or to access tumors that are large and then difficult to access using the transoral route. Another technique is the visor-flap technique, as shown here. Other techniques that can be done openly include the suprahyoid pharyngotomy and the lateral pharyngotomy. Then, in order to achieve free margins, there are other forms of extended procedure that may be performed. This include, especially for tumors that have breached or that has extended into the retromolar trigone or has gone into the mandible, mandibulectomy, either segmental or marginal, may then be done. So, having extirpated the tumor, some form of reconstructions is often performed, and using flaps such as shown below, different reconstruction flaps such as radial forearm free flap, anterolateral tie flap, and bucinator flaps are deployed. So concerns following treatment for patients who have oropharyngeal squamous cell carcinoma have been that of toxicities, especially among survivors. And that has really impacted greatly on their quality of life. And the major prognostic indicator of poor quality of life among survivors of oropharyngeal squamous cell carcinoma who have undergone radiotherapy is dysphagia. And dysphagia is commonly seen in the conventional, especially with the conventional use of an external beam radiotherapy technique. And it's been noted in up to 43% of patients who have undergone this modality of radiotherapy. However, nowadays, the use of intensity modulated radiotherapy have reduced significantly the incidence of dysphagia. But however, even with this modality of treatment, dysphagia and dependency on feeding tube is it ranges from about 4.4 to 8.6%. at 1 and 2 years post-treatment. So addressing this dysphagia may include some modalities, like mentioned earlier, identifying these patients, commencing them on swallowing maneuvers pre-operatively and during treatment, and these are shown here. And then some may have to depend on feeding tube, either using the nasogastric route or using the gastrostomy. These are the chemotherapy-associated toxicities. So the quality of life of patients presenting with oropharyngeal squamous cell carcinoma depends on the HPV status, with those presenting with HPV negative cancers, history of smoking, ingestion of alcohol, advanced disease, advanced age, and high pathological risk features having unfavorable factors and having poorer quality of life. And those presenting with unresectable tumors and with advanced disease should have some palliative care, especially pain management, airway management, and speech and swallowing management, using different modalities, including radiotherapy, painkillers, and chemotherapy as well. So it is important to follow up these patients, especially because local regional recurrence is likely, especially for patients presenting with HPV positive cancers than HPV negative cancers. So the follow-up modalities is as shown. In the first 6 months post-treatment, 1 to 2 monthly, and then 2 to 3 monthly in the next 6 months, 3 to 4 monthly in the second year, and then 6 monthly during the 3rd to 5th year. Then after the 5th year, patients are then seen yearly. And then at each follow-up, it is important to assess patients clinically and then assess quality of life, especially for those who have undergone radiotherapy, and then also for radiological assessment to be done. Look for evidence of primary tumor or tumor recurrence and rebiopsy such lesions when seen. Oropharyngeal squamous cell carcinoma, especially the HPV-associated, is a preventable disease, and some preventive modalities in the primary setting include the use of vaccine. The Gardasil vaccine is effective against the high-risk human papillomavirus subserotypes 16 and 18. And now there is the Gardasil 9 that has a wider coverage than the Gardasil 4. Also avoidance of risk factors such as smoking of cigarette, health education. And then at the secondary level, preventive measures include early identification and institution of appropriate treatment, provision of HPV testing facilities, and also radiotherapy and other treatment facilities, and also the presence of frozen section facility, PET scan, and other diagnostic modalities will greatly improve the rate of diagnosis and institution of appropriate treatment. Then at the tertiary level, prevention could include swallowing and speech rehabilitation, and then reconstruction of some deficits. So in conclusion, the global incidence of oropharyngeal cancers has been on the increase, especially over the last few decades. And the HPV positive cancers have a different clinical pathological behaviors, prognosis, and outcome as shown in the presentation. And then treatment options vary and depends on key factors and local availability. Then preventive measures could play a role in disease burden reduction. Thank you for listening. These are my references. I'll be happy to entertain any questions if you have. Thank you.
Thank you very much, Dr. Dadi, for such a wonderful presentation. Any questions from the floor? Okay, but that was a very nice presentation. Thank you so much. So if there are no questions from the floor, we'll end this session and we'll meet next week, Wednesday. Have a nice day.
Thank you very much.